Welcome, everyone, to the next episode of the YOPN Living Well Starts Here podcast. This is an especially exciting episode today because we have as our guest Dr. Rodolfo Savica from the Mayo Clinic Rochester. I have been a big fan of his since an early video that I saw that he did with a friend of mine, Jamie Bryson, who is the great YOPDer behind the Parkinson's Fight Club on Facebook and now a close friend of mine. And he said something about Dr. Savica that really caught my eye, which is of all the neurologists that he had seen, that Dr. Savica gave him the most hope. And so I want to introduce him, and then let's get into it because he's a very special person to the YOPN community. So welcome, Dr. Savica. And maybe you could just briefly explain a little bit about your background and why you're so important to young onset Parkinson's people, specifically.
Thanks a lot. First of all, thanks for inviting me. It's a real pleasure to talk to you all. I don't think I'm particularly special. I just do what I do, but I'm not particularly special whatsoever. The entire thing is that I have a specific interest in terms of research, but also in terms of clinical practice, devoted uniquely, for the most part, uniquely, I would say. The great majority of my time is uniquely devoted to patients that have the Parkinson's disease and that they are young. That's maybe the different, that what makes me kind of special, but I don't think I have any, I'm not different than anybody else or special than anybody else. I would like just to make sure what I do is what I do, is not who I am. Thanks a lot for the kind words.
I think that you see more of the people that I know with young onset that are doing well and living well than any other MDS in the world, and for sure in this country, if not the world. And so what I'm hoping that we can talk about today is specifically how people with young onset Parkinson's disease are different from those that have the onset of the disease later in life.
So let me tell you something that is very interesting. This shows a little bit what we're talking about. Everything started as usual. I've been a Parkinson specialist, a motor disorder specialist for a number of years, over 20 at this point. And one day, years ago, a patient that I still follow, by the way, still one of my patients, very young, struggling with the diagnosis, seeing multiple neurologists. I finally diagnosed him with Parkinson's disease, and he was in his late 40s. And he told me, there's no resources for us. There's nothing out there. And I'm talking about maybe about 7, 8 years ago. Nothing out there whatsoever. It's very difficult for me to know what's going on. And I, very blindly, very naively, I was thinking it was not the case, because I was taught in a certain way that Parkinson was one condition affecting everybody in a slightly different way, but not necessarily a different condition. So not only this opened my eyes to some of the more stressful and more difficult challenges the patients that have Parkinson's disease at a younger age are having, but also about the fact that we are dealing with a number of different disorders. And I'm using the plural on purpose, a number of different disorders. The age cutoff of 50 and below is what has been defined by the International Movement Disorder Society to identify this group of patients. Clearly, it's an artificial cutoff, because if somebody is 51-year-old, is still, or 54, is still young. It's not necessarily, we don't take this as dogmatic. It's a way that is being done to try to identify population and harmonize the literature and people that are studying the disease. Because in the past, people were calling things in a different way with different ages. And then when you have somebody that define a condition at 45, 50, 30, it's becoming a mess in order to understand what are we dealing with. Likewise, and I want to immediately talk about the elephant in the room. Immediately, one of the things that prompted that I started this journey years ago, talking about young onset Parkinson disease. And then the task force or the Movement Disorder Society, that is a global organization worldwide, not only Anglophone, so not only using the English, involving people that have different background and different languages. After reviewing the literature, after reviewing everything, we thought it was thought by a number of alleged experts that it was better to define 50 and below as early onset Parkinson because it is easier to translate in other languages, and the evidence are supporting that. In Italian, I'm Italian, young wouldn't work. Simply, the translation doesn't work. In French doesn't work, in Portuguese doesn't work, in Spanish doesn't work, in Japanese doesn't work. So, we are trying to be global and try to give guidelines for the entire world about how to define a condition. I know that there have been some issues about definition, but ultimately it doesn't really matter. Matters to me is that we are dealing with a group of disorder that is different than what we see in late onset Parkinson disease. Also because if I say young, the opposite of young is old. And I would not call somebody old Parkinson disease. That's bad. That's not nice. Early, late, young, old. That's English. It's not a different language. So clearly, it's easier to say late onset versus early onset. But I understand the problem, and I don't have any problems in calling things differently as long as we call it the same thing. That's important. What is important, though, and that's I want to point out. I keep saying disorders because when we're dealing with somebody young, for now, I will put aside the social and societal aspect of that, just in terms of biology. What we have a brain that is not frail. We have a brain that does not have, or if it has, it is minimally impacted by cardiovascular burden, cardiovascular disorders, changes in the vessels, minimally impacted by plaques and tangles that we all gonna develop in this call, and everybody is listening to us after the age of 75. Those are the plaques and tangles of Alzheimer's disease. So we have also lower amount or minimal amount, if any, of atrophy. So we are talking about a brain that is inherently, biologically, structurally different than somebody that is 75 or 80. When the disease, the Parkinson disease, the classical Parkinson disease, is affecting the population. Not only, when we look more into the granularity of this problem, of the biology of that, we know that with the name young early onset Parkinson disease, we are defining a group of disorders that share one commonality that is shared also by people in the late onset group: a dysfunction of the dopamine structure, a dysfunction of the dopaminergic pathways. That's the only commonality that all the diseases are sharing. What is the cause that leads to this disorder is very different. Late onset, we know, we all talk about the accumulation of alpha-synuclein, Lewy bodies, accumulating, causing damage, and so forth. Is not always the case in young, early onset patients. Sometimes alpha-synuclein is not even there. Sometimes alpha-synuclein is not even the leading cause of the problem. Can be a bystander, can be there, but it's not necessarily what is causing a degeneration. Or if there is at all a degeneration, we have to also consider that sometimes these disorders are nothing but adult onset of childhood disorder that presented later in life because they were rather incomplete. There's a number of conditions, genetic conditions that we know that are rather partial. They do not present that strongly. They do not present that massively with all the disorders, with all the symptoms, but they present later in life when we are maybe 40s or 50s or even 30. But they are just, quote, quote, just childhood disorder that are rather incomplete. They cause a dysfunction to the dopamine system due to two different mechanisms. So we are talking clearly about two inherent different disorders that have different biology. And you guys know different response, different expression of symptoms, different characteristics. We are unfortunately stuck with the idea, and it's a good idea because we had to do it in a certain way, that to make a diagnosis for Parkinson's disease at any age, you have to have the motor symptoms. You had to have tremor, rigidity, bradykinesias, as well as the movement, falls. But you all know, many of you in the hindsight can go back and think that the disorder, the symptoms started years prior, the presence of tremor, stiffness, or rigidity. Subtle changes. They were maybe not even motor. The most common one is severe anxiety, coming out of a sudden, for example, severe depression coming out of a sudden that does not respond to medication. Why? Because if it's a dopaminergic problem, you have to improve dopamine. You should not work on serotonin or the typical antidepressants that we use in the mechanism of action antidepressants. So we're talking about something completely different. And the difficult part, which is challenging but also quite interesting, is that every patient is almost a unique feature of symptom, syndrome, and everything else. Now we know there are some micro clusters of people that share in some characteristics that can be put together. But the original sin, I don't want to be biblical, but it's important to say the importance of the word. The original sin is to use knowledge for late onset Parkinson into the younger population. That's a mistake because it's not working that way. It's not, the natural history is not that way for all the reasons that I just told you.
Whew. This is why I was so excited about this, because I know these are things that Melissa and Chris and so many of us within the community talk about, but we don't hear anybody else. So, sharing our views. Mel, Chris, what's your hot take on this? What I feel like is a really important moment.
Well, first, bravo. I mean, that's probably the best explanation, summary of what I know Mel and I, and well, all of us have just, discussed, why are the treatments that we're getting, and I'm coming up on, gosh, my 10-year Parkiversary of official diagnosis. And, sometimes some things work and sometimes they don't. And it's, the key that you said that as early onset, I mean, it's a completely different set of rules, I guess, that need to be applied. And I guess the medical community just isn't quite ready for that yet, or it's not hit. How am I trying to say it? It's not hit, I guess, tipping point. I know I've used that phrase before, but like that knowledge isn't there. We're treating it wrong, I guess you could say. And, like you said, it is a collection of different conditions, because I've personally been exploring that myself as to, the whole Parkinsonianism, but I also have hyper reflexibility. And it's, I have dystonia, I have, rigidity that just don't respond to, dopamine. So
No, but
where do you go from there to find the answers when, you go to your doctor, to your MDS, and they're like, well, let's try this, let's up your dosage of Cinemet or whatever, and nothing really happens. So,
absolutely not. You're hitting a very sore spot, but I want to tell you a few things, not because I'm not so. My views are based upon scientific facts and a fact
right.
about studies and about observations and about a lot of studies that we are doing. So they are not necessarily based upon my personal opinion. I want to clarify that. All the bulk of the literature that my group has produced in the last 5 years is pointing to this direction, and more is going into this difference. So it's not just a view, it's really facts that are there, right, reproducible, and they are supported by scientific evidence. But what you're telling me is even more important. I want to tell you something. Years ago, and sometimes I have people seeing after a few years, now I tend to follow them more closely, but in the past it was like every few years. Sometimes people were going away. Being a Mayo, being a high tertiary center, people are coming maybe now and then. They're not regularly coming. And I had patients that I seen at the very beginning, a few years ago, and now. And the amount of tests, the amount of information that I acquire now with every patient is about 5 times more than what I had just 5 years ago. And why is that? Exactly for what you tell me. One of the biggest struggles that I had in my life and a frustration that in my life is that when somebody comes, for sure, and he or she has a dopamine deficiency, we clearly have to replenish dopamine. There's little to say. If dopamine is low, we have to give dopamine. And the best treatment is levodopa, and we can talk more about it, but is what it is. What is the problem? That we know that some people do not respond at all sometimes, or minimally. And why is that? If you have a dopamine problem, why do you not respond? In the past, talking about education, and I was told, and I was taught, if somebody does not respond to levodopa, doing a proper trial without food, 1 hour before meals, doing right, so doing things properly, not just taking whenever, but food is crucial. Not to take it with food, so I highlight that 1 hour before meals is crucial. It's not Parkinson, it's something different. It's MSA, it's CBS, it's PSP, it's all these other conditions. And in reality, it is not true. Now I'm trying to teach my residents, my students, and the medical community as a whole that if somebody does not respond to levodopa, but he or she has Parkinson's disease, is because he or she is not absorbing the medication correctly. And there are a number of genetic factors that are part of our life that are responsible to make us having more problems absorbing the L amino acids. L amino acids are levodopa, levothyroxine, all these other things that we use the same receptors to drive these compounds inside our body. And it's an easy test done in the urine, tells if somebody that has this condition called lysinuric protein intolerance, present 1 every 50,000 persons, so it's not very uncommon. Plus, we know we have a number of genetic conditions, incomplete mutations, so what we call synergistic heterozygosity. So not two complete mutation, but two incomplete mutation acting together that when present make people with Parkinson less likely to respond to the oral agents. And nowadays we have other way to deliver the drug. We can use different formulation. We can use the long-acting capsule like Rytary or Crexont are the new one. We can use the inhaler that currently is used as an add-on, but in my patient I use it sometimes as a monotherapy because it's not for random off. If I want to say something, if somebody has random off, it's my failure. I'm failing as a physician. I'm not able to provide he or she the right amount of medication through the day. Random off is my failure, and we have to be careful as a physician to do that. That's my opinion. And in fact, I don't have anybody who random off. That's for sure. Neither he or my colleagues here at Mayo. Or we have now the subcutaneous pump that, for example, is a way to avoid completely bypass the small intestine. So we have medication that are absorbed in the small intestine, medication absorbed slowly in the small intestine, medication absorbed through the inhaler, so first pass of metabolism through the lungs, and we have subcutaneous medication that, to be honest, I think, if you ask me what is the future, I think that Parkinson will be treated like diabetes. A pump 24/7, press start. Exactly what we do for diabetes that we have seen with insulin in the recent past. So I think that would be where we're going in terms of the field.
Absorption issues is how I have lived since the very first time I took levodopa. So it's just degenerated to the point where like I have a hard time keeping weight on. And I can't eat anything and take my medicine in the same and feel good in the same day. So it's particularly provocative to me because this is how I live. And I've met a ton of people who go through the same kind of issue where anything that they eat blocks the amino acids and you just go downhill. Like I have off cycle pretty much like half the day. So for me, like that all checks out. Like it all checks. I'm just sitting here nodding. I'm a little
absolutely. And I don't know, obviously I don't know your particular case, but clearly genetic mutations can explain this, but not something that is life-threatening. Just genetic mutation that in a different condition would have caused you maybe diarrhea now and then. I mean, nothing massive, but in a situation that you need to take levodopa can cause a problem. Usually I give you some messages that I give to everyone. Carbonation helps. Crushing the pill and drinking with carbonation helps sometimes. I have some patients that had to open up their right artery and using carbonation to make it absorbed. But in a situation like that, the subcutaneous pump, I can see, for example, it can be an option because allegedly, it's not totally perfect, but allegedly, people with subcutaneous pump should have less problem even with food. They can eat whenever they want, whatever they want. And the food should not have the same level of impact. Shouldn't, because it's not totally true. The thing I want to say, there's a medication that is not available in the US, which is called domperidone.
Yes.
It's a medication used for nausea, and all over the world is used whenever people start levodopa, they also start domperidone. The FDA removed it years ago, not for Parkinson, because it was abused by women in childbearing ages to induce lactation. So at a very, very, very high dose, this medication can cause lactation. It can be also causing other problems. At the dose used in Parkinson is minimal. And is actually a medication that sometimes can help with the nausea, can help with speeding up lipid absorption. Is not available in the US, can be found in Canada, can be found in Mexico. I think in Mexico is even over the counter. And sometimes we need to be using this medication to improve that, because what you say is another big problem, especially is a bigger problem when you're younger. And that's an important point that I want to make. It's always a problem, don't get me wrong, always a problem. If you're 85 or if you're 25.
Sure.
If you're 25 or 35 or 45, you have a family, you have a job to keep, you have life to keep, just life. Having the opportunity of feeding yourself correctly, eating correctly, feeling good to do your job, to spend time with your kids, to do stuff, live. I'm not saying anything other than just live. is super important and can be heavily impacted by these problems. Whereas, don't get me wrong, if you're 75 or 80, you can have a very full life. Still say you're 85, and no one to say we don't care about the group of people. But clearly, you're expected to be, I don't say struggle, but less in need of feeling 100% all the time, because you have a job, you have a family, you have kids, you have to drive them around, you have social life. It's very complicated when you're younger. And those are the problems that are impacting the patient the most. Absorption of the drug, response to the medication, and interference with their life. Another problem that we have, and is major, we cannot confuse apple and bananas here. Men and women are different, okay?
Yes.
Please, okay? And we know that. It seems to be silly saying that, but women are different, but they are. They really are, okay? And the problems that women are having are different than what men have. For many different reasons. There's a huge, massive role that is still quite unclear, in a sense that it's not quite well defined, of hormonal changes in women. In fact, you may all know that during the period, there's a group of patients that report that when they have their period, or when they're about to get their period, their symptoms are worse.
Yes.
Way worse. And then it's getting better, maybe after the period. And then menopause hits. And then there's this entire question of, is it getting better or getting worse? Can go both ways. And then do you have to take estrogen? Do you have to take progesterone? Do you have to do any enzyme replace treatment? Those are still quite unclear question. The data are a little bit wishy-washy, in a sense that they're not pointing about using one versus the other. I always tell my patients, my women patients, please be careful about using HRT, or hormone replace treatment is to be done very carefully. I favor progesterone over estrogen, because sometimes estrogens can reduce the amount of bioavailable levodopa into the brain. So there's few aspects that we need to be considering, and yet we don't have too much. Another curveball that I've been thrown many times, which is not a curveball anymore, but it's another thing. What about pregnancy? Talking about men and women differently. What about pregnancy? What are we going to do there? That's another issue that we are having. Pregnant women, can they take medication? For sure, they better not to, in general, any medications, we know that. But if I had to pick one, levodopa is okay. But I will always like to cite Annelien Oosterban from the Netherlands, a fantastic human being, a colleague, a gynecologist that also had few pregnancies when she was not having the disease, few pregnancies after Parkinson's disease. So it's interesting. And then she has the perspective of a physician as well, a gynecologist, so somebody that knows how hormone works. So her work are incredible, her advocacy is incredible. But those are question marks that we are dealing with every day. And that's the difficult part, because talking about medical education, historically, nobody thinks, when I say nobody, bear with me, nobody thinks about Parkinson's disease in somebody in his 30 or 40 or 20. Nobody, because we are not taught about that. The typical onset that we hear and see is a woman. I talk about a woman, typically women that have a lot of delays to go to, more than men, to go to their eye physician. Delays is way longer in women still to these days. And they may be running a marathon, they exercise, and they notice that as they exercise, they have a contraction, a stiffness of the leg. Obviously, what you do, you don't go to the neurologist. You're going to the orthopedic surgeon or the PM&R, say, hey, I have a problem with my leg when I work out. So obviously, if you're in your 30s or your 40s, and you did a few marathons, your knees are rotten already, completely rotten. So for sure, they will find some abnormalities, and they will inject you with steroids or maybe doing this and that, and nothing happens. And then after a while, the stiffness becomes with minimal walking, not necessarily with marathon. And after a while, it comes some tremor maybe in the same hand, same side of that. And then finally you go to the physician. What happened with the physician? The primary says, this is essential tremor. You're 35. There's no way you can have Parkinson's disease. Maybe let me send you to the neurologist. And maybe the neurologist is able to understand that. But even there, epidemiologically, people are not thinking about Parkinson's disease at that age. So there's usually a huge delay, few years before we get into the right diagnosis. Few years that patients are suffering, or worse, they're undergoing unneeded procedures, frozen shoulder, knee replacement, hip replacement, stuff like that. And also days, years that are removed, good years that are removed from the life of the patient, because if you were treated properly, it would be better.
Okay, this ties perfectly into really my biggest question for you, which is, now that we know that gender is a predictor of dyskinesia and wearing off, what is your approach to these patients, and what are you finding most successful as a treatment? I'm asking for myself also because I got dyskinesia immediately after initiation of levodopa therapy. And I find that to be more, I mean, before I even read the studies, and I'm referencing how do you say her name? Palicia?
Lecchia.
The Palekia study.
And we are talking about chromosome X here. We're
Okay.
talking about people that have 2 chromosome X's.
Okay.
Why is that? Because we know the chromosome X is the most important chromosome that we have in our life. Without chromosome X, we cannot live. You can live with 1 chromosome X. We cannot live with 0 chromosome X. There's people that have X0, it's called Turner syndrome. There's no people that have Y and 0. They're stillbirth. So X is phenomenal, is what defines us, and is what a chromosome X has. It's important to say that as some genetic material inside that prevents degeneration. So that's why Parkinson is twice as much more common in men than women, because women have 2, men have 1. So far, we can talk about chromosome X, that gender identification is not, we don't have yet data that support that. I know sometimes there's confusion in nomenclature and the way we say it, but unfortunately, so far we are still talking about chromosome X and sex at birth, because otherwise it's becoming much more complicated. Saying that, I have a woman in front of me, double X in front of me, that comes and start medication because it's time to do, and she develops immediately dyskinesia. Question here is to understand what is the nature of this dyskinesia. Is the dyskinesia a peak phenomenon, something that occurs after 45 minutes, 30 minutes from your taking? Is a wearing off phenomenon, happen at the end of the dose, or is biphasic, happening twice? This is like this. In the past, we have talked about random dyskinesia. They don't exist. It's just a matter of understanding very clearly the pattern to know that. Why I say this difference? Because we know that there are some particular genetic mutations, I keep saying that are defining people to be very prone to low doses of levodopa to develop dyskinesia. But the peak dose dyskinesia can be relatively easily adjusted, smoothing a little bit the curve of the peak. So this takes some time to come up with finding the right dose, finding the right release of the drug. Going back to the concept of before, drug delivery is crucial. Women, unfortunately, they need a little bit more medication historically compared to men, just because of this estrogen role. Therefore, they are more prone to have dyskinesia, allegedly, because they have a little bit more medication that need to be taken. The approach of the dyskinesia is very different. And unfortunately, Esther, it is very much case dependent. Depends a lot, case by case. And there are no clear set of rules in the way we have to approach it. But the set of rules is to minimize the discomfort and optimizing the treatment. That's the set of rule we have to be doing. Medications can be used, other medication can be used, amantadine, now we have the extended release amantadine, so things that can help. But I don't want to jump the gun right there. Sometimes you can reduce the amount of dyskinesia just with some changes in diet, sometimes with some supplement, sometimes you can change it with a different timing of the dosing. Ideally, if somebody has early dyskinesia right away, is a good sign. So you're insane what you're talking about. It's a good sign because it says the medication is working. Medication has an effect. And I think the medication, once it has an effect, there's always an effect. Then it's a matter of delivering properly and make sure it works properly. In a situation like that, the newer formulation or some other newer drugs that are already in the market can potentially prolong the effect of the on time without the need of this peak that are coming every time you take the medication. Let me take advantage of this also to say another thing that is a little bit like what I try to teach my resident, and I am, but the medical community is not really yet surfaced. Typically, we say you have to take levodopa 3 times per day, 4 times per day, 5 times per day, right? In a very regimented way, right? We all agree with that, right? And it's wrong, completely wrong. We are using, as I mentioned before, a concept of late onset Parkinson disease into younger individuals. I say to my patients sometimes, please find the dose that works for you, 1.5, 2 tablets, whatever tablets it is. And you have the ability and you're empowered to change a little bit according to your needs. There can be one day that if you're running a marathon, you have a big meeting, you need more. There can be a day that you're relaxing home, watching TV with Christopher Cat around, right? You need less. Totally fine. And maybe one day you take it once a day only, and maybe 2 times per day only, or 3 times per, depends on you.
So I was at a conference last year, and I was sitting in a room full of your peers, and one of the speakers said, he never has the expectation of, he never gives his patients the expectation of no off time. And I laughed to myself because I'm like, no, that's pretty much my expectation.
Yeah.
If that's not the target, I don't think we're shooting at the same target, you know? And so, I mean, it just, I walked away with that, shaking my head, you know, kind of being reminded once again of this disconnect between what those of us living with the disease, you know, are trying to, you know, have happen and in order to live our lives, but also, like you're saying earlier, with regards to people with the older onset, that I do see, you know, within my own support group, you know, taking the Cinemet 3 times a day for like 5 years at the exact same time with no dyskinesia. They don't know what on off times are. I keep saying, if you don't know what on and off time is, you don't have on and off time, because like I would not need to explain this to you. And so I mean that disconnect is so real, and I think really does speak to what us as advocates and organizations like PMD Alliance, why it's so important that they amplify our voice, but also yours, because, you know, we all want the same thing. We're all just looking for solutions. but it's just the disconnect is so very real, and I just
No,
appreciate
that
that.
disconnect is terrible.
Yeah.
I can agree more. And just so you know, I know that it was frowned upon by many people and whatever. I'm fine, but I still go to sleep at night. So, but the task force of the Movement Disorder Society, now a study group on early onset Parkinson, did not exist up until 5 years ago. Before that, we didn't even have an attention to that, to this group of patients. And what I say to my patients, talking about disconnect, is that do not go to the support groups for Parkinson's disease. Go to the young Parkinson's disease support group. Connect to an organization like yours, YOPD, whatever, even Parkinson Foundation, Michael J. Fox says something specific, or Davis Finney, something specific for younger individuals. Because what you describe, Esther, about patients in their 70s and 80s, their medication trends per day, doing well for 5 years, then obviously becoming demented because you're 82 and you start to have some problems with cognition. That's life. Um, that is not, maybe you start to decline a little, then other problems arise. There's heart attack, cancer, there's neuropathy, then you start to have arthritis, then you come in a wheelchair, you're confused, you have infection. This is a typical natural history of every human being. But this is not what I want my patients to think that their destiny is going to be. This is what we are humans are going to be. We're going to die one day. We're going to die likely for the reason why we all die in the Western civilization: heart attack, stroke, cancer, or car accidents. That's it. Those are the three. And we all going to die for that. But that's why I want to have my patient that have early onset Parkinson, young onset Parkinson, going to support group when not only they can connect with people that have the same problem they have, same social science challenges that they have, but also when their spouses, their caregiver can connect as well. Because I know we're talking amongst each other, but everybody is having a caregiver, a support structure around them, husband, wives, that they are carrying sometimes burdens that they're not used to carry that early. And having other caregivers you can talk to, you can rely on with, is fantastic. I have a group of women that are in the Midwest area that are getting together. They all more or less, some of them are my patients, some of them are not, but it doesn't really matter. We are trying to do a women-specific, women-only consult group at the Mayo Clinic, where women patients are telling what to do. What is that is need? It needs what is that they need. We start with women, but one of the things that they do already, they get together, they have a chat, they text to each other, they're having fun, and their spouses as well. They're getting beers together, and they maybe, I don't want to know what they're talking about. Pretty sure they talk about their wives, but you know what I mean, and vice versa. But that is super important because this is the kind of network we need to create that goes beyond hearing a alleged expert talking about something that they maybe barely encounter in their career. That's what I would say.
Speaking to community is one of the best things that we can do to advocate for Parkinson's, because that's how we connect. Yeah.
Absolutely. But also, let me say something. Not everyone is having this call of advocacy. And not everyone should be feeling forced to do that in order to get information. It means that you guys do it, fantastic. You guys provide resources, others can join. But as long as somebody knows, middle of the night at 2 a.m., when I'm anxious about my life, I can Google, I can see you talking about something. That's exactly what we need.
Thank you very much. I think that this group, at least I know, we all sleep very soundly. Well, not really, because we have Parkinson's and we all pretty much have sleep problems, but we sleep comfortably knowing that we don't agree with a lot of the status quo. But I think that everything that you said resonated and rang true for me. And
Oh, yeah.
I only want 5 more hours of your time.
Exactly. Yeah.
I have pleasure to be seeing, trial to be doing, a lap to run. I cannot do that. I have a lap to run.
Then I won't ask you to dinner. Darn it.
No, I have a lot to run. I have a lot to run, patient to be seen, stuff. So that's the point.
And so thank you for fighting the good fight for us and standing up for what we know to be true and doing the research that will hopefully translate into more of your peers getting on board the ship that has already sailed that we all sail in every day.
Yeah, absolutely. And thank you all for the invitation. It is an honor and a pleasure talking to you. And for everyone that listens, if you have questions, I always try my best, one way or another, to respond to you. So thanks a lot.